Hello, everybody. Recording live from somewhere. This is Zach Couples with episode number 37 of the Movement Debrief. And the one we got tonight, folks, it's alright. We're going to talk about diaphragmatic breathing. How do you coach diaphragmatic breathing effectively? We're going to talk about overhead press. Who, what, where, when, why. And last but not least, we're going to talk about, plantar fasciitis. That's what's on docket tonight. Questions for the people, by the people, and I'm here to answer them. But before we do that, a little bit of housekeeping. Did you guys see my blog this last week? So this previous iteration of the ZachCouples.com bloggery was the Kettlebell Mashup 2018. I was there, course review, and it was phenomenal. I realized how much I suck at kettlebells, and hopefully afterwards I sucked a little bit less, but I'm still not that great. But it was quite a fascinating class. I mean, I was familiar with all the hard style stuff, even though I've never taken a formal course, but I mean, that's just the typical stuff you see. But the Gear Voice Sports stuff, I didn't even know that was even a thing. But what was crazy is GS style kettlebells are actually, or that style of training is actually older than hardstyle by a long shot. I'm talking like this thing's been going on for 80 years. The Russians used it, or maybe they still do for some of their military testing. I mean, it's pretty remarkable, and I think it's a really good conditioning tool, vastly underutilized, and you guys should read the blog and then get your kettlebells in, give it a shot, and see what you think. Otherwise, housekeeping-wise, believe it or not, I actually started editing Project Reflections Eternal, or whatever the hell I end up calling it. Started today. We made a little dent. It's very small, but it's a little dent. So I'm hoping we can get through this sooner rather than later, so I can get it out to you, the people. That's what I'm hoping for. So did that. And also, of course, guys, September 15th, 16th, we got in Seattle, Washington, the one, the only, Human Matrix. It's happening. Hopefully going to get like a pre-sale, pre-order kind of thing going with that pretty quick. I just sent my boy Michael Lee some stuff. And Mauricio, appreciate you, my man. Appreciate you, Pamela, Dana. But I'm hopefully going to get a sign-up for people who've been asking, so you guys can reserve your spots. I hope to see a lot of people there. I think it's going to be a doozy. So that's that for that, housekeeping-wise. Otherwise, life's good. Life is good. That's all I can say. But we'll be done with that, so let's debrief, shall we? First question comes from Tyler. Zach, what is the simplest way to teach someone to diaphragmatically breathe? Something so simple, yet could be incredibly complex. In fact, I had a patient who was incredibly complex for today. So let's talk about diaphragmatic breathing first. What is diaphragmatic breathing? Well, I'll tell you what it's not. It's not this pooch in your belly and have the umbilicus move inferiorly. Nah, fam, it ain't that. A lot more things have to move besides your belly pooching out. So let's just put the kielbasa on that. Squash it. When you take a breath of air in, as the diaphragm descends, you should have 360-degree expansion of the abdominal cavity and the thoracic cavity. It's like a pressurized canister that as things compress down, the body expands outward. It's not just one area moving and then the rest is still. What that allows is for the lungs to fill not just this direction, so superiorly to inferiorly, but also anterior, posteriorly, and laterally. So you get maximum air brought in, and it also allows you for maximum air to get out. So when you are coaching diaphragmatic breathing, it's not just diaphragmatic breathing, you coach the whole thing. You want both these bad boys moving. You want them moving here, up front. You want lateral expansion. We call that the bucket handle effect. Pump handle of the front ribs. You want expansion of the abdominals in all directions. Because here's the cool thing, and I gotta give kudos to Daddy Pops Bill Hartman for this, but the whole entire spine moves into a relative kyphosis as you inhale. So that's the posterior expansion with things. It's pretty cool. And it allows us to manage pressures, both intra-abdominal and intrathoracic, effectively. If you're only doing the belly pooch, you're not getting that. You're screwing up, but you're altering pressure in the abdominal region, one, because most of the pressure is going to be pushed into the posterior aspect of the spine, and then you're not doing anything here, so you get a huge reduction in intrathoracic pressure because of the position that you've put the diaphragm in. So what we want for an effective diaphragmatic breath is 360-degree expansion of the thoracic and abdominal cavities. Period. P-U-R-E-D, as Charles Barkley would spell it. How do you coach it? Well, there's a few simple ways, besides in through the nose and out through the mouth. I think a lot of it depends on your infrasternal angles, which I will link to that once I find... Man, you know what? Every time I do this show, I forget something to write on. But if you look at one of my past debriefs on infrasternal angles, I talk about what type of breathing strategies you ought to use. So, with a wide infrasternal angle, so ISA and Bill, with a wide infrasternal angle, you want a forceful exhale. Pause, get all the air out, then a silent inhale. That's going to get you maximal diaphragmatic breathing because it helps attempt to restore that 360-degree relationship that we are looking to attain with our people. So there's that. With the narrows, it's a little bit of a longer open mouth exhale. I'm coaching people to like 5 to 8 seconds, get all the air out. Pause, silent inhale. Those are kind of the basic strategies that I use. But what if you run into someone who can't even get in through the nose, out through the mouth? Because this is where I think that the challenges lie. I had a guy this last week who I probably get this type of person once every 4 or 5 months, and it is just mind-boggling. But this gentleman, he had a couple strikes against him, and I feel bad because it's typically the people who you can't get them to even coordinate in through the nose, out through the mouth. They are typically hard of hearing, which this individual was, and he didn't speak English that well. He spoke predominantly Navajo, and my Navajo skills are not the best. So we had to teach this guy how to just learn basic breathing. Forget about the infrasternal angle. Well, actually, don't forget about the infrasternal angle, but he was a wide infrasternal angle. And so what I did for him was this. We tried, breathe in through the nose, out through the mouth, and all he did was this. And then if I said in through the nose, it would be this. So we couldn't get just nose for inhale, mouth to exhale. So what do you do in this scenario when you have someone who just can't coordinate that? You choke them. Let me unpack that a little bit before someone calls 911. So what I did was I gave the guy a straw, and we used the straw to try to achieve a forceful exhalation. Because he was a wide infrasternal angle, I wanted him to get as much air out as humanly possible. And so what I ended up doing was, if this was my straw, this pencil, I would put my finger over it during the inhales. So he couldn't inhale, so he'd have to do this, or he'd go through his nose. I'd do that enough times, and eventually he got it, where he was able to go in through his nose, and then I would release my finger as he would exhale. So what did I do? I made sure he couldn't breathe when he wasn't supposed to, where he wasn't supposed to. And so we put him in a position where he had only one strategy, and that was to go in through his nose. And even on the times where he would still try to breathe in through the straw and he'd just go like that, I was still happier with that than I was with him just going in and out through the straw. So typically, for someone with a wide in this case, if the goal is to achieve some type of abdominal tension to close the infrasternal angle, if you had to pick one thing, you want to emphasize the exhale so they can achieve that diaphragmatic breath. And if I was struggling with this guy and we just couldn't get that to happen, as much as it pains me to say this, I would almost be cool with him mouth breathing the whole time. Simply because we're at least getting him to get out as much air as humanly possible, and he's able to set the ribcage in a good position to get the goal that we're trying to get for that. Now, in a narrow case, flip-flop that. I wouldn't use a straw or anything like that, but if you held me at gunpoint, don't do it, because then I'll do a Steven Seagal move or something. I don't know why I chose him, but that's the first guy who came to mind. And for those people where they are already really good at creating tension in the abdominal region, I might not use, I might just cue them, if they can't figure out in through the nose, out through the mouth, just simple nose breathing. Because they're still going to at least get some air out. They're going to get air in silently, and they're not going to create excessive tension, which is the problem with these people, because we need them to get as much air out as humanly possible, and everything is already tensed in the abdominal region, which is why the angle is narrow. Okay, 3 eggs, cheese, and hot sauce. Sorry, what's narrow versus a wide infrasternal angle? I'm sorry, I should have explained that. That's not a dumb question. But the infrasternal angle is the angle of the rib cage below the sternum. So, on me, there's my sternum. It's that bad boy right there. So it's these ribs, just like so. Put that on your calendar series, people. So that's what the infrasternal angle is, and that's what we're trying to change with a lot of the variability style treatments that we're doing. So that's typically how I coach diaphragmatic breathing with most people. And a lot of times when I'm doing this and then I'm implementing it into a movement, I get the breathing piece down first and foremost. And this is that's hilarious, Adil. But this is especially true when I'm working with someone online. So what I'm doing a lot now, because I can't always hear via the interwebs, is I have them get creepily close to me on their screen, and we go through the exact same breathing strategies that I'm talking with you guys. So forceful exhales for the wide, easy exhales for the narrow, silent inhales in both cases, 5-second pause before or at once you get all the air out. So I think it's critical that we spend time coaching these people and making sure that they achieve the technique in the manner that we so desire. So to summarize, wide infrasternal angle, we want a forceful exhale, pause, easy silent inhale. Straws work great, balloons work great, spirometers work great, any type of resistance, even just putting your hand up against your mouth and blowing through the hole that your hand creates, solid option. If they can't put the in through the nose, out through the mouth together, as much as it pains me to say it, you're probably better just coaching the mouth. In the narrow case, we wanted a long, prolonged exhale, open mouth, 5 to 8 seconds. I tell my peeps, imagine I told you the worst joke of all time, and you have to match that with an equally long sigh. Pause, silent inhale, and if push comes to shove and they can't coordinate these two things, just nose breathe. And you should be in business. Tyler, an outstanding question from an outstanding human being. Next question, Vic. Overhead pressing. What do you ideally like to see before clearing someone to press? What are you looking for positionally during the press? And how to breathe / maintain ribcage position? It's a lot of questions, Vic, and I'm going to answer every one of them. So, overhead pressing. I'm going to make the assumption that Vic is talking about all types of variations, so kettlebell, dumbbell, single arm, basically anything that is pure vertical. I'm not talking landmines. I'm not talking any horizontal pressing. We going vertical. We going over the head. So what do you ideally like to see before clearing someone to press? If we go back to our infrasternal angle section, what I would say for these people is that depending on what angle you have, I'm more likely to push you overhead in one case versus the other. For example, with the wide infrasternal angle, because we're generally throwing the arms up overhead, so that generates abdominal tension, I may be more likely to put you there sooner than I would the narrow. And that's because the narrow is already very long anterior posterior, and as you go arms overhead, you're enhancing that longness, that increased anterior to posterior dimension. So for those people, I'm not going to be overhead pressing them right away. Wide? Absolutely. Or at least I'll be doing a landmine or something close to where we're going that, because it forces them to generate a little bit more abdominal tension when they have something in that position. So that's just right out of the gates. I'm already thinking those things. But there's a few other things too, Vic, that I like to look at to clear someone to overhead press or not. And so what I'm looking at for these people is I would like to see a decent amount of shoulder flexion. Okay. Vital performance, I will answer your question. That's a really good question. So for the overhead press, I want to see at least 165 flexion of the shoulders, and that's passively. Now, that doesn't always translate actively, but if they don't have full shoulder, like if you have someone who had a total shoulder or something like that, or someone with rotator cuff in the early phases, you're not going to be using that much. I mean, it's not a wise move to make for those types of people. So you want to make sure that shoulder flexion is there. I also think, well, really just having full shoulder mobility, period, or at least close, is pretty good. Because sometimes you'll get people who have limitations in internal rotation, and they go ahead and press overhead, and it's painful, and then you restore IR, and then life is good. Well, why would that be? Well, it must be because of the way that the arm articulates in the overhead position, because as I go here, I external, but then as I'm pressing overhead, I probably go into a degree of internal rotation, one, and two, having full shoulder mobility or degrees of freedom within the shoulder joint allows you to clear more space to effectively go overhead. So is that a deal breaker? It is if the person's in pain with pressing or in their shoulder. If they don't have full shoulder mobility, but technique-wise it looks okay, then I'm probably okay clearing them to overhead press. So I would say so far what we're saying is, one, can they do it with good technique? Because some people can do things with great technique despite having limitations, say, in variability or a particular infrasternal angle. But that would, to me, would be number one. They have good technique and they find and feel the things that they need to feel. They're not feeling things that they don't want to feel. Then I would go check out the infrasternal angles. If they don't have that, who am I more likely to get there first? Wide first, narrow would be second. And my third tier would be looking at shoulder mobility, especially flexion, IR, external rotation, all of those things, and can they do they have full excursion of the joint? A lot of times if you have someone who has limitations in rotation either direction, instead of kind of doing the J press like you might see with a kettlebell press, sometimes just going right here and keeping it in almost pure flexion seems to be a bit more effective, seems to be a little bit less stressful to the joint, and I think it's because it puts it in a less of an end range position. So sometimes that's a little intermediary or surrogate that you can utilize before you go out to the side. Just something to consider with your overhead pressing people. So that was the clearing things. Positioning wise, what do I look for? Well, when someone goes overhead, what I like to see is, hang on one second. For some reason my comments on Facebook are not working, so I apologize, people. What do I look for positionally during the overhead press? What I want to see is, as they're pressing overhead, ribcage stays relatively locked down, and they're not achieving any degree of lumbar extension as they do it. The only case in which I might be okay with not lumbar extension but hip extension is if you look at how the overhead press is classically taught. Or some of the Gear Boy Sports stuff with kettlebells. In those positions, hopefully y'all can see me. Yeah. In those positions, they're kind of locked out like this. So the hips are extended, knees are extended, and then they go overhead. And what that does is allows you to clear your face out of the way. And if you look at like starting strength or something along those lines, when they're coaching overhead pressing, the move is doing a little bit of, not lumbar extension, but you're getting hip extension so you can clear your face out of the way to get it overhead. To me, if you do that with good integrity and technique, I don't really have a problem with it. In fact, that's how I overhead press, if I elect to do that. Because when I try to go straight, I get shoulder pain. Why? Because I don't always... Well, I have full shoulder flexion sometimes, but I don't always have good clearing of that in standing for whatever reason. There's probably a few reasons. So I'm almost okay with those kind of things as long as you are maintaining a good ribcage position. So how do you coach that? A lot of the strategies I talked about regarding Tyler's question are fair game for this. So what you're going to see is, as I exhale, which whatever strategy you're going to use, ribcage is going to drop. Now what I'm going to do is I'm going to keep that, and as I inhale, to give myself a little bit of pressure within my thoracic region, that's going to give a little bit more stability for the scapula and the glenohumeral joint to sit on. Inhale, then go overhead. That's typically how I coach something like an overhead press, especially if we're going heavy. If it's not heavy, I don't sweat that as much. But just like with any lift, you want to make sure you're attaining some intra-abdominal and intrathoracic pressure. And so you would coach it the exact same way. You just ensure that the rib cage stays in the position you want it to, which is slightly dropped down, not flaring, and that will limit lumbar extension. But hip extension, a lot of cases I'm actually Gucci with it, especially if it doesn't hurt. So to summarize all those points and all that stuff that I just talked about. So clearing, first off, can they do it with good technique? That supersedes just about everything. And, even if someone has limitations and variability, doing something like an overhead press, doing something like a bench press, doing something like a squat, it's a skill unto itself. Just like variability is a skill unto itself. And if it looks good, it doesn't hurt, they're getting the adaptations they so desire, that's number one for me. Second tier, wide versus narrow. Wide, more likely to put them overhead because that might help reinforce the ribcage position. Probably not super heavy weight though. Narrow, they're going to take a little bit longer. Then I'm looking at shoulder mobility because that's going to allow the joint itself to have enough degrees of freedom to be able to push something overhead. Coaching wise, I want to make sure the rib cage stays in a good position so it's kind of dropped down, achieving a zone of apposition. If it's heavy, take an inhale before you lift. That way you achieve intra-abdominal and intrathoracic pressure to be able to axially load yourself with an overhead implement. And that's my thoughts on overhead pressing, Vic. Phenomenal question. Before I go into the last one, Vital Performance 1 on that Instagram baby asked a question. How does visceral fat change the ability for a person to get a ZOA? Big time. Big time, big time, big time. The short answer is you can't. Because if I have all of this central adiposity present in this region, it's really hard to overcome and drop any rib cage or drop the ribcage into the position that it needs to. And that's because there's fat in the way. The ribs have nowhere to go to achieve a zone of apposition. So with these people, you do the best you can. Another piece to that oftentimes is if the stomach is large enough, the abdominals are so eccentrically oriented due to the stretching from the visceral fat that they just can't generate enough tension to achieve that zone of apposition. So while I typically advocate that variability is first, then power, then capacity, in this case, you may throw that out the window and prioritize fat loss first and foremost. Because sometimes that can be the best thing that can happen for that person from a huge health standpoint, not just from achieving variability, but think about all the health benefits that you can get from losing weight. So it's very, very tough. And I would say if you're working with someone and you can't have that conversation right off the bat, maybe you're their physical therapist and you're only seeing them for a few visits and you can't undergo a fat loss program. You just do the best you can. You treat that individual regardless of, based on what their infrasternal angle is, typically wide for these people, and do the best you can. And you can still, even though if you don't change an infrasternal angle much, you can still elicit very good benefits. And the way you know you're getting good benefits is if you look at some of your other testing that you're doing, whether it's shoulder motion, whether it's hip motion, whether it's whatever. So be looking at all times at some of your other markers to let you know you're heading in the right direction. So, vital performance 1, really good question. Last question comes from Tyler and Lucy. This was a popular one, so I figured I'd answer it sooner rather than later. Plantar fasciitis. What's really happening? What can cause it? How could you help a client work around it? Guys, I'm glad you asked. What is plantar fasciitis? In theory, if we look at the definition, it means inflammation of the fascia on the plantar surface of the foot. So there's a huge thing of fascia on the underside of the foot. In theory, that gets inflamed and problems ensue. Is that what's really happening, though? I really don't know. And the reason why I really don't know is because there are so many tissues on the bottom of the foot that I think it makes it very hard to pinpoint it, that it's one structure versus the other. I'll give you one big example. The medial and lateral plantar nerves are oftentimes right around where people complain of their plantar fasciitis symptoms. So how do you know that it's not an issue with those nerves? You also have several muscles within the region. You have several tendons. You have a lot of different things that could potentially be impacted in a case of plantar fasciitis. So I think it's really hard to say that that's what's going on. Now, could be? Absolutely. But we also have to look at other potential structures. What can cause plantar fasciitis? A lot of things. That's what makes really anything that we do tough, is because I think, especially something like plantar fasciitis, you can have a lot of potential variables that influence that. Foot type, body mass. If you have some type of disease like diabetes, for example, that maybe impacts your connective tissue, that could potentially lead to you developing something like plantar fasciitis. There's really a lot of possible influences as to what could be causing this. But I don't always sweat the cause. What I sweat is, how can we address these symptoms? And how can we get them to a place where they're moving in the way they want to, our clients? And for these people, the strategy is very much the same as it is for any other condition. You're going to improve variability, build power, build capacity. So a lot of the stuff I've talked about, infrasternal angles, the things I've talked about regarding pelvis, a lot of the things I've written about, that's top tier for these people. It's no different than anyone else. And a lot of times you can address those things and get some really good changes in terms of symptoms for plantar fasciitis. But I do think there's some specific things that we could consider with the foot and the heel and the position that the foot lays in that can have a favorable impact on symptoms. So, let's talk about that. 1. What position is the foot in at rest? Or not at rest, I should say. That's not wise. But what is the foot? What position is the foot in when they're standing? Because I think you can have two plantar fasciitis, scare quotes, problems with two very different foot presentations. If I'm someone, where's my shoe? If I'm someone who has a more pronated calcaneal everted foot, they fall in like this. Well, that's going to put a little bit of pressure on that medial calcaneal tubercle where the plantar fascia resides and attaches. And so if they're always like this, and it puts the plantar fascia and the other structures on the bottom of the foot on a relative stretch, well, you have a tissue that is stretched out. Because they're never offloading that because of the stretch position, you probably get an ischemic response and problems ensue. So what do you got to do? Well, you got to get them here so they can offload. A neutral, relatively neutral foot position. How do you do that? From a movement standpoint, one thing I like to do is perform moves that emphasize left lateral heel contact, because they're already typically on the medial heel or the medial border of the foot, more so than they are on the outside. If you do that, so maybe something like a posterior hip stretch or a single leg squat where you're shifting your weight back on that left side, squatting down, putting most of your weight on that outside heel, not so where to the point where you're supinating, but you're bringing them back to a neutral position. So you're just shifting your weight to the lateral aspect and then you're squatting down. A lot of times you'll find and you'll see that a person can put weight on their foot without any pain when they shift over to that position, because you alter where pressure is on the bottom of the foot. You take the structures on the plantar aspect of the foot out of a stretched position, and then you get a little bit of increased blood flow back in the region because you don't have this stretched tissue getting ischemic, and people get happy. So that's one thing to consider. Another thing to consider, though, is I could have plantar fasciitis in the exact opposite presentation, a more of a calcaneal inverted or supinated foot. This requires a different strategy. Here, instead of tissues being elongated, they're a little bit more tense, compression. These types of things can have a similar ischemic-based response if they're overly contracted. Same pain, different fix. For this person, we got to evert them to neutral. How do you do that? Simple. You might do something, if it's my left side, where I'm pronating my foot, trying to find and feel my arch, and then I'm moving the knee back to center to get myself the booty. Right there. Because arch position or eversion of the foot and gluteal activity, especially if you look at some of the research with ankle sprains and PNF for that matter, those two guys go hand in hand. So you do that to help offset the supinated foot position to a more neutral foot position. Now let's say that they can't achieve those positions on their own and they need a little bit of help. Do you go to orthotics? Not yet. First off, it would help if they got a good shoe. What's a good shoe? What I look for, and I will link the PRI Rescue Clinic shoe list because they oftentimes have some good shoes. But what you look for those people is you want a stable heel counter, because the calcaneus If you have control and stability of the calcaneus, that allows for the foot to kind of go through its rolling action that it normally does during the gait cycle. So we want that to be stable. Can't move it. Whereas with this shoe, now let's not get it twisted, fam. I like my Nikes. Bam. No heel stability. But I still get after it. Next thing we want, forefoot to be flexible. Toe box. Typically your first met head's going to be right there-ish, pointing up. Last but not least, we want, now this is not the best shoes to demonstrate this, but we want the middle of the foot to have a pretty stable arch. This foot, or this shoe, you can't really do that so much because I can wrap it up like nothing. So those are things to consider. But let's say you work with poor people or a lot of individuals who can't afford nice shoes. But you got to give them something. You got to give them a little something to help them out. For those individuals, and even for these individuals who have the nice shoes, I like modifying the shoe wear a little bit. So for my person who is pronated in their foot, calcaneal eversion, I will put a medial heel wedge in. I wish I had these here, but it's basically just, I'll link them in the show notes. Wedge and arch. I'll put a medial wedge in their shoe to help tip them back to center. Sometimes if this person has a really flat foot, you can also put an arch support or an arch pad in the shoe as well. That can be very helpful. If it's the converse where it's a supinated foot, I do the exact opposite. I put a lateral wedge in the shoe to tip them, and then I put an arch pad in there as well so they can find and feel the arch. Doing those things are often really helpful strategies to do in the short term or sometimes in the long term to help reduce the sensitivity. And a lot of times you can get by without going an orthotic route by just doing that. If those two things have failed and we're still running into problems, orthotics are something to consider. It's been a hot minute since I've referred for orthotics. In fact, since I left the league, I haven't referred for orthotics. And I think that's partly because I think we underemphasize addressing axial skeleton position and all of these things to even warrant going towards some type of orthotic intervention. I still think you can get pretty far without them. One other thing to consider is what I had mentioned way back when, but the medial and lateral plantar nerves are oftentimes right along where people are exhibiting symptoms. And so checking your neurodynamics, so a slump test, straight leg raise, or not even that. Guys, very simple. They have a painful movement, like walking or, I don't know, whatever. Have them flex their head or round their back with the head flexed and have them perform the exact same movement and see if it makes a difference. If it does, you probably have some type of neurodynamic issue. And so what do? You would do activities that would increase mobility of the nerves or help mobilize the nerves. Oftentimes I do this after variability has been taken care of for the most part. So for that, maybe even doing just what I did is a good example of an exercise. If they have pain with those first few steps in the morning, which is very common, have them tuck and flex and have them walk, and then you can have them move their head up and down. I mean, it sounds crazy, but when you're in that position, you're creating a relative glide of the nerves within the foot. So you can use that as a potential treatment, and I think it's a vastly underutilized treatment for people with plantar fasciitis. So those would be the things I typically gravitate towards when I am working with someone, establishing variability, managing shoe wear if necessary, using neurodynamics. And from a manual therapy standpoint, I haven't found much success with a lot of the different manual therapies that I use personally. There is one that does work. I had someone who was complaining of plantar fasciitis and it worked pretty slick. But this is absolutely, for me, the last resort. And that would be dry needling. literally had a guy who had, this was when I was in the league, but I had a guy who was complaining of plantar fasciitis pain that just started up, and it was kind of a little bit of a flare-up. And he was having a hard time just moving up and down off the court. And so what I do, I was like, well, I tried some things, wasn't getting much symptom relief, and I said, how you feel about needles? And he's like, yeah, I'm cool. So I just literally poked a needle, hit him on the medial calcaneal tubercle. Wasn't really painful for him. He is a better man than I. I was, ugh. But I did that, twirled it around a little bit, took it out, walked up, had no pain. And as painful, as uncomfortable as it can be, seems to be effective. So that is another potential treatment you could consider. The reason why I think of it as a last resort is because it is so damn painful. Whew. I never wish that upon my worst enemy. But that's a potential manual intervention you can use. I have also had some success on a less intense note with doing some soft tissue mobilization along the nerve tracts. But I found that you can get similar benefits by doing neurodynamic-based interventions. So, do you want to spend 10 minutes rubbing someone down their nerve tract? Fine by me. I'd rather spend time doing other things. But I would do it if fam wants it. Let's not get twisted. So, that's what I would say I do from a plantar fasciitis standpoint. So, to summarize that one more time, it's not always the plantar fascia. You have to look at all the structure of the foot. You establish variability first and foremost. Things to do with the foot. If they're pronated, do things to get them supinated to neutral. If they're supinated, do things that get them pronated to neutral. That can be with exercise. That can be with orthotics. That can be with modifying shoes. That can be with buying good shoes. Also, I would consider, and this is something I just kind of thought about, but we're doing those things. You also want to ensure that there's adequate dorsiflexion, because what that does too is that will put the heel in a good position to allow for full supination or pronation. Now, I'm not stretching calves relentlessly, but putting them in positions to where they can either push their knees forward via squat or they're doing some type of downward dog move, those can actually be pretty effective for reducing symptomatic complaints, because if calves are on, body weight is shifted a bit more anteriorly, problems ensue. So what do? You got to find ways to get them posteriorly, waist shifted posteriorly, and that almost supersedes going into something with supination or pronation, because if they can't feel a heel, you're screwed. So something to consider as well. So do that. Then we got neurodynamics, very useful for these people. Last but not least, I would use manual therapy. I would, as much as I hate to say, I gravitate towards dry needling because it hurts. And that would be like how I would incorporate things from a treatment standpoint. Now, sometimes people are still going to be training while they have plantar fasciitis. So what do you do there? I think anything where you're getting heel contact is going to be money in the bank. So, that is something I have not done. So Jenny, and I can't pronounce your last name. Is it Hesse? Sorry. But I went to school with Jenny, but she had a different last name when I knew her. Dry needling gastroc with plantar fasciitis patients. I have not done that. I don't needle that much, but when I do, I will consider that next time. But it would make sense to me because it would do something that would reduce the tonicity of the calves, which would alter foot position, which would alter how the posterior, the plantar aspect of the foot is stressed. When they're training, anything where you're getting heel contact in the places that they need money, deadlifts, money in the bank, squats. Remember, we're getting that excursion of the gastrocnemius, money in the bank. Step-ups. If you put the heel where they need to feel it, you in business. What I would be careful of, though, is anything split stance. And the reason why is because when the involved foot is the back leg, you're typically in this position where your great toe is extended. That creates what's called the windlass mechanism. And what that does is essentially puts the plantar fascia on stretch. And if it's stretched and it's already symptomatic, it could potentially make that worse. Something you kind of sort of want to be careful with. RDLs, money. Anything upper body, of course, is fair game. But those would be the things I would consider. You want to try to keep comfortable heel contact as best as you can with these people. And if they're very symptomatic, then you just use your offloaded lower body variations if you're trying to get gains lower body. So hamstring curls with a physio ball, leg press, might be okay. And I'm just thinking, guys, we still want to get a training effect. It's not this functional versus non-functional BS, which we don't, maybe that's another debrief discussion, but let's not go there tonight. But just think about things that could potentially hurt this person and don't do them until pain starts to subside. Whether you're doing things from a movement standpoint like I've talked about as a clinician, or if you're a coach and you want to do things that improve movement variability, you have my blessing. But I think that's probably a good stopping point for tonight. I want to thank all of y'all for tuning in to tonight's debrief. It was a doozy. I hope you guys liked it. And yeah, I hope you guys had a good time. Hope you enjoyed me answering the questions. If you have questions, don't hesitate to comment on this debrief and let me know, and I'll add them to my list. It's ever growing. But I answer your questions, peeps, so that's why we're doing this. But I know you guys are wondering, wait, Zach, don't leave. I want to know more about you. I want to know everything about you. Or at the very least, I want to know where I can find you. I'll tell you. First off, go to zachcouples.com. While you're there, click on my newsletter. It's there. So you go to the right, it's on the newsletter, and you subscribe to it. Guess what you're going to get? You're going to get almost 3 hours worth of talks. A talk on pain, a talk on respiration, almost 50 pages of notes. You'll get a free acute to chronic workload calculator. You'll also get access to a podcast I'm in. And guess what, fam? When Big Z be, releasing his products and stuff like that, guess who'll be getting the discount? It'd be the fam. And fam recognize fam. Sign up for the newsletter right now. Go ahead, I'll wait. Now that you've signed up for the newsletter, don't leave zachcouples.com just yet. You want to go to the online services page. And there's 3 things I offer. Movement consultations, mentorship, online fitness training. Let's dive into each. First, movement consultations. Maybe a little toy. And maybe you aren't moving as well as you'd like to. Maybe you can't achieve depth in the squat and you want to be able to do that, for crying out loud. Maybe you've been to some practitioners, you've ruled out the big bad stuff, and you're like, yeah, you know what? There's something else going on, and I just need to figure out maybe optimizing my movement is going to be what helps me. Well, guess what? If you click on the movement consultation page, scroll all the way down, fill out your information, send it to me. We'll arrange that. We'll make it happen. I'm going to look at how you move in all 3 planes. We'll find out what you can't do, make you be able to do that. We'll find out what you do too much of. We'll make you do less of that. And we will maximize your ability to move, which will help you reach your health and performance goals. Hit me up for a movement consultation. Once you've done that, you're going to click on the next one, and that's the mentorship program. Maybe you got some troubled clients that you'd like to bounce some ideas off of. Maybe, just maybe, you want to get your clients moving a little better. You want to get them doing that conventional deadlift, and you don't know how to address the variability side of things from that. Maybe you want to learn more about neurodynamics, or maybe you got some processes that are a little bit inefficient within your day, and you want to streamline things so you can be as productive AF. I'm your boy for that. Hit me up for the mentorship program, and we'll go through solving these problems together, and we'll both be better for it. Once you've done that, you're like, you know what, man? I want to get jacked, or I want to get lean, or maybe I just injured myself, and I want to still train. Well, then you want to go to the online fitness training. Sign up. I'll give you a program. We'll go month to month. We'll talk week to week. We'll get you meeting your health and performance goals, and we'll get you looking how you want to. Hit me up for online fitness training. Once you've scoured zachcouples.com and you've seen enough pictures of me on my headers for my blogs, you're like, oh my gosh, I never want to see this human being again, but he's got a nice voice. Then you want to go to iTunes, search the Zach Couples Show, and you can listen to these debriefs, which, by the way, guys, there's 36 others of them. If you haven't listened to them all, you can sign up for that. Listen to me in your car. Talk like I'm talking right now. And then while you're there, make sure you please leave me a little review on iTunes. We need more fam present. The bigger the fam, the bigger the party. So check me out on iTunes. Once you've done with that, then you want to go to social media. And first, we got to hit me up on Facebook. Facebook.com/ZCouples. Once you've hit me up on Facebook, you got to go to Twitter. The handle is also ZCouples. I'll tweet things here and there. Sometimes I have a profound thought or a not profound thought, or I get angry, or I ask a question and I just tweet it. That's where you'll find that. And of course, you know you got to hit up that Instagram, baby. Instagram.com, Zach, Z-A-C, Couples, C-U-P-P-L-E-S. You definitely want to hit me up on that, especially if you want to see pics of my hikes. You want to see quotes. You want to see all that kind of stuff. You got to check out Instagram. Last but not least, go to YouTube. Just search Zach Couples. Hit the subscribe button, because guess what? You're going to find moves that I be doing with my peeps online or offline that I don't put anywhere else. So you'll definitely want to check me out there. Otherwise, guys, it's been a wonderful evening. I hope you enjoy the rest of your week and your weekend. Until next week, keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, stay moving, and I'll see you next time. Deuces.